Good afternoon and welcome to today's Made by McGill Alumni webcast. Is COVID on the rise? My name is Derek Kassoff, Managing Director of Communications at McGill's Office of University Advancement, and it's Thursday, December 14th, 2023. Just when many of us thought we were finally done with COVID-19, a rise in cases is forcing us to rethink whether the virus is truly behind us and what we might want to consider as we prepare to celebrate the upcoming holidays with loved ones. And as hospital emergency rooms fill up with patients stricken with COVID, flu, and other seasonal infections, doctors and other healthcare practitioners wonder how much more strain our fragile healthcare system can absorb. Joining me today to discuss the current progression of these viruses and the state of our hospital network are two of McGill's leading experts in the areas of global health and infectious disease. Let me introduce them. Dr. Timothy Evans is the inaugural director and associate dean of McGill's School of Population and Global Health and executive director of Canada's COVID-19 Immunity Task Force. And Dr. Jessie Papenburg is a pediatric infectious disease specialist and microbiologist at the McGill University Health Centre, an assistant professor in the Department of Pediatrics at McGill's Faculty of Medicine and Health Sciences. Thank you, gentlemen, for joining us today to share your insights and answer some of our questions. Before we get started, a note that if you're watching us live and if you have a question for either of our panelists, you can email us at aoc@mcgill.ca, and I'll do my best to address them to our guests. So let's get started. Dr. Evans, welcome back. Maybe I'll start with you. To begin, can you contextualize for us the current uptick we are seeing in COVID cases here in Canada and elsewhere in the world? Reports I've seen suggest that wastewater samples indicate that there could be twice as much virus circulating in places like Quebec and Ontario right now compared to readings taken a year ago. And maybe a little bit less scientific, but just about everyone I speak with these days, myself included, seems to either have COVID or is recovering from it. So are either of these barometers accurate measurements? And does this increase surprise you at all?
Well, first, thanks, Derek, for the question. And I think the barometers that you mentioned, wastewater and what you learn around the water cooler, are in fact likely to be accurate at this point in time. The former perhaps much greater than the other, but both I think are showing what we have really learned throughout the pandemic, which is SARS-CoV-2, the virus that transmits, responsible for COVID-19, is full of continual surprises. And I don't think there isn't a person in the world who would have predicted the evolution as it's happened. And I think we've been humbled continuously over time for all sorts of different reasons. And this is a continued legacy. The viral dimensions of this is continued evolution of the SARS-CoV-2 virus, which has moved in a technical way from a mutation related to Omicron, which was around XBB, to something called BA 2.86, and a new variant within that called JN.1, which is really just a location on the spike protein. And that has led to increased contagiousness of the virus and also increased immune evasion. So this virus is outfoxing us again. It continues to evolve in a way which is promoting its transmission. And indeed, it's not just in Canada, it's in Europe and the United States, where you've seen very strong signals being picked up in wastewater starting in November, which are suggesting that we have a new surge related to this JN.1 variant. And with that, of course, we're seeing increases in infections. And there's a group in the United States that is trying to estimate new infections associated with this surge. And they're talking about hundreds of thousands of new infections per day. So for us in Canada, that probably means that there are tens of thousands of new infections per day across the country. And so, yes, what's being picked up in parties or when you talk to folks who about somebody who's come down with COVID or tested positive for COVID, I think this is a reflection of this latest evolution in SARS-CoV-2, which we're beginning to adjust to.
Mhm. All right. Well, thanks for that context. Dr. Papenburg, maybe I'll bring you in. You're a physician and a microbiologist, so you probably understood a lot more of what Dr. Evans just explained than I did. But so let me just get your take on this. This surge that Dr. Evans is referring to that we're witnessing now, is this, in your opinion, sort of just a seasonal occurrence that we're experiencing because we have colder weather and people are indoors and virus, tends to spread more easily? Or is there something happening at the microbial level that is giving energy to sort of these new strains of the COVID virus?
Well, I guess I'll handle the seasonality aspect of that question first. So we've been expecting, many of us expected COVID to be a seasonal respiratory viruses, as pretty much all other respiratory viruses are. Now, each virus can have a little bit of a difference in terms of when it tends to circulate, but most respiratory viruses do peak in the wintertime, as do the other endemic coronaviruses. So people were expecting that once we went through a certain number of waves, that eventually we would wind up in a seasonality. It hasn't panned out that way yet. But it kind of stands to reason that it's not unexpected that as we've gone into the late fall and early winter, that we've seen an increase in transmission of COVID-19, if only from the way that humans interact, at least here in Canada, in that we spend more time indoors, where the transmission of the virus is easier, less time outdoors. So it's not unexpected that we would have, if a virus is present in the community, that it might be easier to spread during the winter months as opposed to the summertime. Mm-hmm. Now, how much of it is the virus? I guess part of what you're also asking was, has the virus changed enough to increase the transmissibility? And I think Dr. Evans was pointing that out, that the virus will continue to evolve. And that's just the natural selective pressure that the immunity as a population we've acquired from previous infections, as well as from vaccination, is exerting on the virus. So, and we see this with other respiratory viruses. For instance, influenza tends to change gradually from one year to the next, based on the fact that it's quote unquote trying to evade the immunity that the population got from the most recent infections. So it's not surprising that you're going to see this evolution, and it's not surprising that as the virus changes, it can be transmitted more often. But one thing that I'd like to highlight is that the wastewater signal, yes, it's high, and wastewater signals have tended to precede the more severe cases that require hospitalization, for instance. And certainly we had a nadir in the summertime. In other words, a low point in terms of wastewater signals, the percentage of our tests that were coming back positive for COVID, and also in terms of our hospitalizations. And yes, hospitalizations have been creeping up, but we're not seeing the same type of explosion in terms of hospitalizations that really put like tremendous stress on our healthcare system in the initial waves, nor during the Omicron wave. And part of that has to do with the fact that the immunity that we're acquiring is allowing the population to, in general, to be more protected against severe outcomes, either because of prior infection, because of vaccination, or both. But because the virus changes, the protection against a milder infection is still, clearly far from perfect.
Mm-hmm. So I do want to come back on that point shortly about the sort of what sounds like almost like a cat and mouse game between science and the virus. But I just want to build on that point, and maybe I'll go back to you, Dr. Evans. You talked about potentially tens of thousands of infections a day in a country the size of Canada. So what do we know about these latest strains and the health risks? Do we need to be as concerned as we were at the outset of the pandemic when so many fell ill and we had so much mortality associated with this virus? Or are we now talking about, a lot of infections, but milder outcomes more in line with the common cold?
Yeah, so I think a good question, and just drawing on what Jesse was describing is, I think that over time, through either vaccine-induced or infection-acquired immunity, our ability to withstand the virus in terms of its negative impacts related to hospitalization or death has improved. I think one of the big challenges, however, is with increased transmissibility, many more people are infected. And therefore, the absolute numbers of people that need care or that may die remain alarmingly high. So some of you may have seen in 2022, Canada lost a full year of life expectancy at birth. It went down from 82.3 to 81.3 years. So that was largely driven by deaths due to COVID-19 in 2022. You'll remember in 2022, we had the Omicron variant, right? It was also the time when we were peeling back all of the public health measures and opening up. But what happened during that year is that even though Omicron was much less lethal as a variant, it probably 1/10 as lethal as the original wild type virus back in April of 2020, May of 2020. There were 27 to 30 million Canadians that were infected during that year. Okay, and that constitutes, again, when you have even at 1/10 the mortality rate, that with that increased number of people being infected, we ended up having the most COVID deaths at any time during the pandemic, right?
Wow.
We had, and so this as Canada's third leading cause of death. So what I think is so important for people to remember, when you have something that is so transmissible that virtually everybody is susceptible to getting it, then the absolute numbers mean that you can get a very high numbers of hospitalization and deaths, even though it's not nearly as lethal as it used to be. So it's much more than the common cold. It's much more than the flu. Flu deaths in Canada, 4,000 to 8,000 per year. We had 20,000 deaths from COVID in 2022. Now, it may be that we move with time, as Jesse indicated, because of better protection from immunization. And let me state once again that if you look at the deaths in Canada, they're disproportionately amongst those people that have lower levels of immunization, either no immunization at all or incomplete immunization. So I think that first, this is much more severe than the flu still. And it's something where if you can get a booster, you should take it because there's great evidence that vaccination helps prevent the worst outcomes related to SARS-CoV-2.
Okay, and hold that thought because I do want to talk a bit more about vaccinations later in this conversation. Dr. Papenburg, let me switch it back to you for a moment. I'm wondering if the healthcare profession, of which you're a part of in your clinical work, is the profession better equipped to deal with the more severe cases of COVID that do require hospitalizations? In other words, thinking back to where we were in the spring of 2020, do we have a more efficient way to triage these cases? And are there more effective therapies to treat the illness in serious cases?
Well, compared to the spring of 2020, we are way better off in terms of our ability to detect COVID and test and get results quickly for our patients that are presenting for care, whether it be in an emergency department or in hospitals. We have also obviously much more experience in terms of the myriad different ways that we need to treat COVID-19 patients that are severe enough to require hospitalization. So now, not only in terms of we know better what are the ideal supportive cares in terms of the types of ventilation and things like that, but now we have tools at our disposal, medications that can help reduce the risk of ICU admission or reduce the risk of mortality when they're in the hospital. So some of these medications were well known to us before, and they affect the immune system. In other words, they're immune modulators that blunt some of that really potent inflammatory response against the virus that our own body is creating, but overwhelms also some of our organ systems. So using simple things like steroids have been shown definitively now to decrease the risk of mortality due to COVID if you're hospitalized for it and require oxygen or mechanical ventilation. But we also have now specific antiviral medications that have also been shown to improve the outcomes of hospitalized patients. So there's one antiviral now that's really, the evidence has mounted that by using remdesivir in patients that require oxygen therapy once they're hospitalized, but are not so sick to already be requiring mechanical ventilation. So if you catch them at the right time, that also improves their outcomes. And there have been multinational studies, but also Canada has contributed to that knowledge about the use of that treatment. And also, perhaps even more importantly, now we have medications that we can give by mouth that in patients that we know are at risk of having a severe outcome of COVID-19, that if you take that medication, you reduce the risk of requiring hospitalization. So that's really one of the things we want to get to is how do we treat the patients before they get hospitalized, where they run the risk of all sorts of bad outcomes, but also they put additional strain on the healthcare system during these very busy winter months. So that's why Paxlovid is used. And in Quebec, there are indications in whom should Paxlovid be given if it meets certain criteria with regards to age, the presence of some comorbidities, and especially immunosuppression. There's sometimes patients who are on other medications are not eligible to take Paxlovid because there can be some drug-drug interactions. And for those patients, if they meet criteria again, you can give a version of remdesivir intravenously once a day for 3 days through an outpatient procedure, again, with the goal to be in these high-risk patients to prevent them from winding up requiring hospitalization. So yeah, from a management perspective, we've learned a lot about COVID in terms of diagnosis, supportive care, immune modulatory therapies, and now specific antivirals that we can give both in the hospital and before patients are sick enough to require hospitalization.
Okay, so that's a pretty encouraging response, I suppose. But I'm looking at you, Dr. Evans. I wonder if that is a very Canadian or North American response. What's happening sort of at the global level? We've had so many conversations earlier in the pandemic about, how, the developing countries were having, a hard time, first of all, getting vaccines and trying to get COVID under control. Are these therapies and medications now widely available around the world, Dr. Evans, or is there still this big sort of health gap between the world we live in and other countries elsewhere?
There remains a huge health gap. And I think this is a function of a realization in the context of the pandemic that we need not only a research and development, but a production capacity and a delivery capacity for life-saving drugs, which are for the service of 8 billion people in the world rather than 1 billion people who live in rich countries. And so I think that situation has not changed fundamentally. It is moving in the right direction because I think there was a huge wake-up call because of the pandemic that we really need to think about a decentralized and global capacity for the development of these new vaccines and therapeutics, as well as making sure that every region of the world has access. And so we've seen in this year's leadership of the G20 from India, a very explicit focus on regional capacity for production, R&D and production of life-saving technologies. I think that's a move in the right direction, but there's a huge distance between the policy direction and actually making that happen on the ground. There's a lot of challenges related to building the capacity, the infrastructure, making sure it meets good manufacturing practices, good standards that you'd want to make sure that you'd had anywhere in the world. So I think it's a road that has a lot of bumps in it still, but I think we're moving in the right direction.
Okay, great. Well, great start to this conversation so far. A reminder, if anyone is watching live and you have any questions for either Dr. Evans or Dr. Papenburg, you can send them to us by email at aoc@mcgill.ca, and we'll try to leave some time at the end to get to some of those questions. Dr. Papenburg, let's maybe move away a little bit from COVID-19 specifically. I'm curious if you can tell us a little bit about what's happening with sort of the hospital situation in general here in Quebec and perhaps elsewhere. I mean, just in the last week, we saw media accounts about overcrowding in emergency rooms, including reports of, I think, 2 patients dying while waiting for care at a facility on Montreal's South Shore. I mean, so with all of these viruses circulating in our communities, how concerned should we be about the situation in our hospitals and our healthcare centers right now?
You're right that currently in Montreal, emergency departments are at overcapacity, probably around or close to 200% of their capacity. And that's true both in terms of pediatric emergency rooms and adult emergency rooms. And it's not unusual. In fact, I think most winter seasons we would run into the same problem as you have this constellation of different respiratory viruses, in particular influenza, which disproportionately affects the elderly, but also the very young. And in pediatrics, respiratory syncytial virus, which is the leading cause of hospitalization in children under 1 year of age. And they both have a seasonality that tends to overlap, not completely, but when those two are circulating at the same time with other respiratory viruses also, year in and year out, our healthcare system has a hard time dealing with that winter surge. And it's now even more evident when you add on to it COVID-19 that is circulating at the same time. Now, people have thrown around the term triple-demic of RSV, flu, and COVID-19. And it's a little, I don't know if the word alarmist is correct to describe it, but sensationalistic perhaps. But it's not, it's the accumulation of the burden of each of these when they circulate around the same time of year. Our system just doesn't have the leeway. We're already at the best of times working at capacity at many levels, whether it be outpatients, emergency departments, operating room availability, ICU beds to take care of post-op patients, and also to take care of patients coming in sick from the community with infections or other issues. So I think, it's unfortunate that we're kind of beating on the same drum and people are sounding the alarm year in and year out, that I think that Canadians deserve a healthcare system with an increased capacity that can handle what we will see every winter in this, when we get an increase of respiratory viruses. And I'm not even talking about, having to deal with a pandemic where a new virus comes out and maybe spreads at another time of the year or on top of the other viruses or has an even greater lethality. So I don't want to sound pessimistic, but I do want to pass along the message that this is not new, and we have been struggling with this year in, year out.
Mm-hmm. I'm not sure if you caught the fire engine sirens that literally just went by my office. That was not planned, I guess appropriate. But maybe we could talk again and just a bit. You mentioned pediatrics. I know that's your specialty. And I know last week, the medical director of the pediatric emergency room at the MUHC put out a public call urging parents not to bring their kids to the hospital unless they were in need of urgent care. Is it a similar situation? Is it even worse at the pediatric level in Montreal right now?
Oh, well, we're right in the midst of it. I mentioned that RSV is really our number one pathogen in young kids and leading cause of hospitalization, emergency department visits. And we're at about 20% positivity rate in children right now in Montreal, which means that we're still on the upswing. So we're really in RSV season, and we're starting to see influenza now. We haven't hit, I think, the threshold for the influenza epidemic or seasonal epidemic, which would be somewhere between 3 and 5% positivity, but we're almost there. So in pediatrics, we're not out of the woods yet by any stretch of the imagination. And what that makes me think of when the medical director of a tertiary care university affiliated pediatric center is telling people, please seek care somewhere else, or if you can. It's that somewhere our children don't have somewhere to go for these relatively minor ailments that could be handled in other types of walk-in clinics, or the mini type of emergency department clinics, or even by their own family physician or pediatrician that would be able to find them a slot to see them, and maybe either just give reassurance, give indications for what are the things that the parent needs to look out for if the child deteriorates. Sometimes there might be a minor infection that could be treatable, like an ear infection or a strep throat. But we don't need a university center to handle those cases. But the problem is families have nowhere else to go. So that is another issue that is not new to 2023. And we need to find ways to get care for the urgent care, but not necessarily emergency room care, to the families that need them, and help decrease the load on our hospitals.
Right. Sounds like a whole other webcast right there that we could do on that topic. Dr. Evans, I'm wondering how much of this hospital overcrowding would you attribute to a healthcare system that has been so battered and beaten down these last 4 years, and that is, dealing with severe shortages of nurses and other essential staff?
So I would just concur with Jesse that I think you have an acute on chronic situation. The last 4 years have been particularly difficult, but it isn't as if there weren't challenges before. And I think what Jesse described and what you're pointing to is a pattern of massive systems neglect, and no focus on really thinking about what constitutes the health system's most valuable resource, which is its people, its health workforce. And if you look at the amount of research, Derek, that has been done on understanding simply the demographics of the health workforce, the numbers related to need, you can't even measure it as a research priority in Canada. It's not even a tenth of 1%. And if we have no intelligence on how to manage growing needs, if we have no intelligence on how to manage the fact that 25% of Canadians don't have access to primary care, then of course, when somebody's got the sniffles or sick or they're concerned about their child, they'll take them to tertiary care institutions or the emergency rooms at tertiary care institutions, because that's where people like Jesse are, right? Great clinicians, and you want to get the best. But we have underinvested fundamentally in understanding about how to build up the front lines of our system so that they're truly universally accessible, and underinvested in such a way that in order to get the people that we need for those systems, we're not training more Canadians, we're going overseas, and we're poaching health workers from other countries that are struggling to provide care to their own citizens. Mm-hmm. And there's no accountability for this across our provincial, territorial, jurisdictional settings. Recruitment agencies in all sorts of places are having a bonanza because they're being told to recruit more nurses, more social work, or more care workers for long-term care homes and things like that, and no concerns as to where they're coming from. So yes, we have this is not simply the last 4 years. This is a big blind side to the Canadian health system that we really need to address by understanding the nature of the challenge and reinvesting much more fundamentally in strengthening our system's most valuable resource, which are its health workers.
Mm-hmm. And I suppose with an aging population, people living longer, I guess, with more variety of illnesses, it's just going to be exacerbated even more in the years to come.
That's right. You're absolutely right. And this is why understanding the demand side of it, or the needs side, yes, our populations are aging, but so too is what you're talking about, the comorbidities, the fact that many people don't have just one illness, they have multiple illnesses. And those are complex and they take a lot of care. And it's people, even though we are going to have advances in AI that may help and facilitate that, we really need to think much more creatively and resourcefully about how we can make sure that people aren't the primary constraint to accessing our so-called universal system.
Okay. Well, now I'm even more depressed. Thank you. But so just to get a reminder, if you have any questions, depressing or otherwise, you can send them to us at aoc@mcgill.ca. I see a couple are starting to come in. And in fact, the first question actually just came in, which is I wanted to move the conversation to back to COVID and prevention tips. And the first question has just actually come in. I'll get to it right away from Professor Brian Lewis, who says he's flying to the UK tonight. And he writes, I doubt many people on the plane will be wearing masks. Should I? Either of you want to jump in on that one?
It would be unlikely that in the near future, unless there's a big shift in COVID-19 virology, that we have another huge surge in the way we had with Omicron, where Omicron, when it first came out, is very different from the other viruses that had COVID viruses that had circulated, the other strains. So we really had, as Dr. Evans said, a huge number of cases. But barring that, I think that there's not much of an appetite from decision makers to impose things like mask wearing. So it comes down to personal decisions, because you're going to be where you're going to spend your time and who you're going to be exposed to. Some things you can't control, but you can control the level of protection that you can offer yourself with a mask, as an example. Now, planes are a little bit of a tricky situation because they actually have really good air circulation. So we don't know really well how transmissible COVID is in an airplane. On the other hand, we also feel kind of trapped in the sense that we're stuck next to a few people for several hours. And if one of them does have COVID, if they're right next to us, there is a significant chance that you could catch it. So I don't have a one size fits all answer for should I wear a mask in an airplane. But if you are concerned about catching COVID, either because of your age, your comorbidities, because you care for somebody who is at risk for severe COVID, or maybe just you're on a business trip and you really can't afford to get sick 48 hours after you land, wearing a good quality mask, so preferentially either an N95 or a K95 or a good fitting surgical mask, will decrease your risk of catching it. Now, is it worth your discomfort? I've tried wearing an N95 in an overnight flight. I have worn it, and I did wake up at one point with a certain amount of almost air hunger. It was almost distressing, but I was able to, I persevered and I made it through the flight. So it comes down to a personal decision in terms of what are your risk factors, what is your tolerance for the risk of getting infected, and can you tolerate the best way you can reduce that risk, which is wearing a good quality mask and frequent hand washing.
Okay. Dr. Evans, I know the holidays are just around the corner, and in past webcasts, you've been a big proponent of rapid testing. Is this something you would recommend if you were sort of invited to a big holiday party with family, perhaps some elderly guests, people who may or may be immunocompromised? Are we still suggesting that people do rapid tests before they attend large events?
I think, first of all, the rapid tests are still very useful to understand whether or not you have acute infection. They're not 100%, so it's not fail-safe. But certainly, if you tested positive, then that would be important in protecting others. And so if you have access to tests, or if you're concerned that you've been exposed or you're feeling symptoms, then I think those are indications that would suggest you should consider doing a rapid test. So I think, yes, for people who are concerned that if they were positive and that they might be exposing others who might be particularly vulnerable. Oftentimes at holidays, we're meeting with in multi-generational settings with parents and grandparents. I think it's not a bad idea.
I know the tests are sometimes hard to get a hold of these days. I guess I was quite fortunate. We seem to have a stockpile in our house. Um, do they expire? I think they do have expiry dates, and there's obviously a liquid component. I mean, is there an expiry date that we need to be aware of?
There is. Both the FDA in the United States and Health Canada have looked at that, and they've extended the expiry dates of the rapid tests that are available in Canada. And what that means is that look at the manufacturing date, and it needs to be within 2 years of the manufacturing date. That is your expiry date. The previously perhaps stamped expiry date on the box may be shorter than that. But now Health Canada has said 2 years. We expect these tests to be able to perform as accurately at 2 years as they did when they first came out of the factory.
Huh, so they can just do that, change expiry date. Like,
That is under their purview. Yeah,
you're gonna get them on
but it's based on
Yeah,
it's obviously based on the data they have on how the function of these tests evolves over time. Things to be careful though. Obviously, these things need to be stored at room temperature. You wouldn't want to have an open box under getting exposed to daylight for extended periods of time, as some of these tests, all these tests have a degree of a visible line that you need to see, and that might exposure to UV light for extended period of time might affect that. So my one caveat would be, if you left it in some place that is outside of room temperature, either very high humidity or exposed to UV light in an open box, I would not use those. Otherwise, if they've been stored adequately, up to 2 years is expected to work fine.
And Derek, I might just add that in addition to what Jesse said in terms of making sure they've been stored adequately, understanding that the expiry dates have been extended, they still need to be executed properly. And sometimes that's perhaps a bigger indicator of not getting a result, which is they're not inserted and managed properly in terms of getting the sample and managing it in the solution. So paying attention to the instructions and doing it properly is also very important.
Right.
And can I add one thing with regards to rapid tests and the holiday season that's coming up? And Tim said it can be a good idea to do rapid tests before, and I agree. But rapid tests do not, a negative rapid test does not exempt someone or give someone a free pass if they have symptoms. Because first of all, for COVID, we know that the rapid tests can be falsely negative very early in disease. So if you just started having symptoms, your rapid test might only become positive 2 days later or the next day, and you have a true infection. The other thing is that if you have symptoms, even if you don't have COVID, you might have something else that for you is just going to be a cold. It's going to be an annoyance. But RSV in a 75-year-old with chronic obstructive pulmonary disease might put them in hospital. Influenza in a 6-month-old might put them in hospital. So I would just say, it's unfortunate, but if you have symptoms during the holiday season, don't go to the big holiday gatherings.
Yeah, Derek, let me just build on that because Jesse's telling my autobiography here. I tested positive for COVID in September, but I was feeling symptomatic 2 days in advance. And for 2 days, I tested each day and tested negative. And it was only on the third day that I tested positive. And part of the reason that I was particularly concerned about my symptoms was that we had a big event here at the school, launching a new department and things, and it was actually that the symptoms that said, "Hold on, we got to protect people," and then sure enough, on the third day, I did test positive. So I think just exactly what Jesse said, you can have symptoms before you test positive, but then I think just as importantly, he said, even if it's not COVID, you want to protect people from potentially other bad infections like RSV or flu.
Right. And that was exactly my experience when I had COVID a couple of weeks ago. It was really on I guess, the end of the second day of symptoms that I eventually tested positive. So I'm sure I was contagious before then. Sorry, Dr. Papenburg, you wanted to jump in again?
Oh yeah, and I just wanted to put on advocate as an advocate of for child health and a pediatrician. Babies under 3 months of age, especially during the first month of life, that's when they really can run into trouble with any respiratory virus, RSV or other. And even, and they could also, because they're so young, if they develop any fever, they do require to be to see a physician, possibly requiring hospitalization to rule out a serious bacterial infection in those first couple of months of life. So we need to be careful with our elderly population. We need to be careful with adults with severe comorbidities, but those young babies are particularly vulnerable. So during those first 3 months of life, we want to try and cocoon them and make sure that people who come to visit don't have any respiratory symptoms at all.
Mm-hmm. All right, maybe that's what FaceTime is for to meet the newest members of our families during the winter, at least. So sticking with the issue of prevention, Dr. Evans, let's just go back to the issue of vaccines again. I think it's something like over 85, maybe close to 90% of Canadians have been vaccinated for COVID. I guess those initial two shots. And yet the percentage of the population that has actually, completely stayed up to date on the government's full recommendation of vaccines and boosters is much, much lower. Can you speak to that? Is that an issue of, it's not an issue of access. Is that complacency at this point? And how critical are vaccines and boosters to our ongoing battle with COVID?
So it's an important question. And I think there's a certain degree of complacency that comes in over time that's related just to the duration of the pandemic. However, it's more complex than that, because during the Omicron wave, and now as we're seeing with this new wave, which may be linked to a new variant, the vast majority of Canadians have also been infected. So we had great uptake of the vaccines. Canadians were amazing in the rollout of vaccines in terms of the adherence and uptake. And so we had very, very high levels of full vaccination and very good initial boosters. But what's happened since that time is the majority of people have also been infected. And so you have this phenomenon of what we call hybrid immunity, where you have immune protection not only from the vaccines, but also from an infection. And so that, I think, has made a lot of people say, well, I had the infection and it wasn't so bad, and therefore my immune system is perhaps a little stronger now because I'm building on 3 vaccines. And therefore I don't need a booster. So that mentality is creeping in. The problem with it is that it is perhaps underestimating the reality that we're looking at essentially new types of bugs with the evolution of the virus, as I described early on. And second is that the new booster vaccines have actually been developed in such a way that they are more specific or useful with respect to these new variants. So both the Moderna and Pfizer vaccines, not only were they good for what we call the Omicron-related variants, but this new variant that I described earlier on also benefits from that new booster vaccine. So they remain important, particularly for populations that are at risk. So elderly populations, people with immune compromise, people with multiple comorbidities, there should be no complacency whatsoever with respect to making sure that those populations get their boosters. And my expectation, if we looked at the data, and I don't have it, but my sense is that, given that Canadians are full of enormous amount of common sense, is that the full adherence with those latest vaccines is probably very high in those populations.
Well, that's encouraging to hear. Yeah, Dr. Papenburg?
Yeah, I would just add that in Quebec, we know that right now, who is more at risk of getting hospitalized? It's definitely over 80. No matter if healthy or not healthy, you're over 80, you're much more risk of getting hospitalized due to COVID. Over 60 and you have a comorbidity, you're also at high risk for getting hospitalized due to COVID. And these are the populations that really want to try and make sure that they get their booster. And getting a booster means if you haven't gotten infection in the last 3 months and you haven't gotten vaccinated in the last 6 months, these high risk populations are due. And now's the time. And it's annoying because every 6 months, nobody wants to go get a shot every 6 months. I get it. But these particular populations, the 60 plus with comorbidities or anybody 80 plus, as well as people who have immunocompromise, as well as pregnant persons, because pregnancy is a higher risk state for COVID-19. And it's also been shown that vaccination during pregnancy reduces the risk of COVID-19 in the newborn for the first months of life through a passive transfer of maternal antibodies during the third trimester. So these populations, we really want to continue to encourage to get vaccinated because we're not just preventing infections in them, we're preventing hospitalizations and deaths.
Okay, great. So we have a few minutes left with our two guests. Again, if you have any questions, do you want to send them in, you can do so by email at aoc@mcgill.ca. We have a couple more here. Here's one from Lori Helens. So she's writing, there's been no mention yet of the serious medical issues that can arise after an acute infection, such as cardiovascular problems, rapid onset of dementia, diabetes, kidney issues, as well as long COVID, which can cause serious disability. How do you want to jump in on that? I know it's something we haven't spoken about here, but I guess that's still a pretty, beyond obviously morbidity, it's still a pretty serious issue related to COVID.
Yeah, Jesse, why don't you go ahead and I'll follow.
So I think there's a couple of things in that question where you have there's the element of that people when they get COVID and go to the hospital need hospitalization, especially in older adults. It's not just for their respiratory condition. It's not just that they have a COVID pneumonia. There are many other reasons that will push them to require hospitalization. And often it's an exacerbation of their underlying medical conditions. So they come in with worsening heart failure. They come in with worsening kidney failure. They come in with an exacerbation of their chronic pulmonary disease. So that's where a lot of these comorbidities do come into play. It's not necessarily a classic respiratory infection presentation. And we see the same thing for influenza. We see that influenza vaccination reduces the risk of myocardial infarction during influenza season in people who already have predisposing heart disease. So we hope that that vaccination against COVID also will help reduce these kind of immediate sequelae. And then you get into the longer term effects, these post-COVID conditions that are actually a myriad of different symptoms that can persist for 12 weeks or more. And a lot of them have to do with cognitive function. Some of them have to do with energy levels, pulmonary reserve. And we're just scratching the surface of understanding what is it about the virus that triggers these responses in various organ systems in the body and that produces really sometimes debilitating symptoms for an extended period of time. Unfortunately, we don't have good treatments yet. Things have been tried in terms of like an antiviral, but we do know that there are some things like occupational therapy, physiotherapy that can help with this. So if you're suffering from these symptoms for more than 12 weeks, there are post-COVID or condition clinics, formerly known as long COVID, where you can perhaps get some help for that. Mm-hmm. It's a concern for sure.
Yeah. So the only thing I would add to Jesse's answer and on this issue is first, the numbers are really large. So the estimates in terms of the number of people who are living with the post-COVID condition, which is the greater than 12 weeks sequelae, which, as Jesse said, have multiple manifestations. So it's not easy to put your finger on just one dimension of it. Those are, as many as 5 to 10% of people who've been infected. So that's a large number in Canada, and also their needs for care are huge. The second dimension of this, which I think is really important, is the evidence suggests that there's protection with vaccination. And this is so important. Again, it hasn't been emphasized enough, but not only are there benefits to not getting hospitalized and not succumbing to COVID-19 arising from vaccination, but also there are benefits related to the risk of having post-COVID syndrome or post-COVID condition. So those are just two supplemental points on Jesse's answer.
Great. So let's move on. I have a few more questions have come in. I'll put this next one to you, Dr. Papenburg. This goes back to some other comments you made earlier about the state of our healthcare network, at least here in Quebec. This question comes to us from Bob Telequiti. So he writes, as I recall, CLSCs were established to resolve the problem of access to medical facilities for less severe infections. Does this mean that the system is no longer working?
I mean, you're right. CLSCs are part of the solution. And unfortunately, they are also underfunded, understaffed. Some of them are only open from 9 to 5, and it's something. We need more things like CLSCs where people can go to when they need either non-urgent care or semi-urgent care. And also, even before that, where they can get primary care and prevent some of these visits later on if they're taken well care of initially. So CLSCs are. I'm not trying to. I don't think that CLSCs are a failure. I think that as the rest of the healthcare system, they've been underused, underfunded, and not optimized. And hopefully they can provide some answers for us.
And Dr. Evans, you've observed medical systems all over the world. So what's your take on this?
So I just want to build again on Jesse's comment. I think the CLSCs, when they're introduced almost 30 years ago, terrific idea because they bring together that front line, not simply with respect to health services, but also broader social services that we know are sometimes critical adjuncts to keeping people healthy and in the community. And I think we need to think about how to revitalize those fundamentally in the context of reforms in healthcare. And coming back to the point that I made earlier, that they have important workforce needs that aren't being met and things. Just an anecdote on this, I happen to have an aunt who lives in Montreal who is in her 90s. She benefits enormously from a well-functioning CLSC and somebody who visits her in her apartment every day and makes sure that her various conditions are being well managed. The benefit to the health system there is enormous. She's been managed at home, avoided not only visits to emergency rooms, but also hospitalizations. And I think we have to give a little bit more value to those frontline providers who actually keep people healthy in the community.
Mm-hmm. All right. So we've got a few more questions. We'll try to get as many as we can in the next 5 minutes. Dr. Evans, maybe I'll send this one to you. It's a bit political. I know you've been involved, McGill political. I know you've been involved with McGill administration on some of the COVID policies. Question comes to us from a professor here, Leslie Breitner. So our question is, I'm quite worried that we continue to allow sick students to sit in crowded classrooms. What is to be done? Are we allowed to require masking when we know there are students with symptoms who refuse to stay home?
I think, so thanks, Leslie, for the question. I think it's important for us to remind students to take responsibility for not only for their health, but also for their colleagues in the class. And there's virtual options now for accessing classes, which are perhaps not quite as good, but certainly possible. And so to me, this is an issue of not having an edict from the university, but rather reminding that we all have to play our part as health citizens. And students can exercise that good judgment, or should be encouraged to exercise that good judgment, which is not simply taking care of their own health, but also being sensitive to the health of people around them.
Okay, great. Here's a question from Angela Williams. She says she's been hesitant to get a booster because, well, she writes, I had several side effects in previous ones. In recent months, I've heard from physicians, including panels at McGill, that not all side effects have been disclosed in previous vaccination campaigns. I now have a fear of vaccines I did not have during previous waves. Dr. Evans, take that one.
Well, I'll go quickly because I think Jesse probably has even more insights on this. But as part of our COVID immunity task force, we supported the Canadian Immunization for Research on vaccines, and looked at vaccine safety in the rollout and monitored side effects. And in all of the studies that have come in, the side effect profile of the vaccines has been very, very benign, meaning there haven't been any major red flags that have said, boy, we've got a huge problem. And this has been, surveillance on vaccine side effects in multiple different ways. If you, for example, people were very concerned about myocarditis in young people at one point in time. But if you look at rates of myocarditis amongst those people who weren't vaccinated in that same age group versus those that were vaccinated, you had much lower rates of myocarditis in the vaccinated population. So the evidence that we supported through the COVID Immunity Task Force that was generated, of course, independently through these studies, didn't point to the vaccines having major problems with respect to their side effect profiles.
Okay.
But Jesse, you probably have a more intimate view.
Well, I think that if we take a step back, that the COVID-19 pandemic has further polarized people's opinions on vaccines. So people who were hesitant may have been now more prone to refuse because of what they hear, what they see, what they read. And others have become real proponents of vaccines, especially those who had underlying conditions that put them at risk for COVID-19. So that's one thing. But as we rolled out several different new vaccines, and we rolled them out to different age groups across the country, and actually across the world, what we saw was that the surveillance for adverse events following immunization works. Myocarditis as one case in point, where we're talking about rare occurrences, along the lines of 1 per million to 12 per million, 20 per million, depending on your age group. So very unusual occurrences, but still something that we needed to monitor because we were seeing this signal, and better give advice to people with regards to that, and keep it as transparent as possible. Same thing when there were serious thrombotic events that were associated with the AstraZeneca vaccine, especially in older individuals. Some people use that as an example of, oh, look at they're changing their mind with the vaccines, and they're changing the age groups for the indications. But it's actually just a fact that as we did surveillance, as we were monitoring for either common and side effects or more rare side effects that were severe, we were able to pick up these rare side effects and make sure that we use the vaccines in the safest way possible, and make recommendations based upon that, and make sure that the vaccines that we're giving were offering Canadians much more benefit than they were risk from side effects.
Okay, great. So I see we're at the top of the hour. I'm so sorry I'm not able to get to all of the other questions that have come in and continue to come in. But I think we will have to bring this webcast to a close now. Before we sign off, just to remind everyone that this video will be available at this very same link soon after our recording ends. So do feel free to share with others who may not have been able to tune in live. I would, of course, like to extend my deepest gratitude to our special guests, Doctors Tim Evans and Jesse Papenburg, for joining me today and offering such great insight and knowledge of COVID and infectious diseases and so many other tangential topics, especially as we prepare for the upcoming holidays. To our viewers, please accept my warmest wishes for a holiday season full of peace and comfort. And please be sure to stay tuned to your McGill email and social media feeds in the new year, as we will continue to share news about our exciting online and in-person programming. Until then, please be well and stay safe. Thank you.
Thanks, Derek.
Thanks.